All right, bacterial meningitis. What is meningitis, first of all?
Inflammation of the meninges.
Meninges. And where are the meninges? What are they?
Cover your brain.
Yeah, like protection for your brain and spinal cord, right? Yeah. Okay. So if you get meningitis, this is like a brain infection and a spinal cord infection. This is very bad. Okay. Like a lot of blood goes to your brain.
Yeah.
So you can get sepsis like really fast, and babies with sepsis do not do good. Okay. So this is a very big, bad, ugly, terrible infection. Let's follow through the whole patho first. Okay. So if it starts with a brain infection, usually it starts with something else, like ear infection that can travel to the brain, right? Or like, something up here that travels to the brain. They get meningitis. It'll get into their blood, and that is called sepsis. They may call it septicemia. Okay. But your body goes through like all over. Something is wrong. And they almost get what looks like DIC. That is called meningococcemia. You will see the purpura, the petechiae. They start clotting in some places. They start bleeding in some places. So you'll see, this kid looks very bad. And so remember with DIC, you have to make some choices, right? So this is how kids with meningitis can end up losing limbs. They'll have to cut off that limb. I know, this is serious. Because they have a clot in it and I can't give them TPA. Okay, so meningococcemia can lead to you losing limbs, and then the kid could obviously not make it. I want to show you all this because it is incredibly extreme.
Is that rare?
No,
Oh.
it happens a lot. Because some of the symptoms are very vague, and so we don't catch it until it's too late. So how it's going to start out when they're getting meningococcemia is they're going to start getting purpura like this. Okay, now this is bad. Obviously, if I saw that on a kid, I'd be like, that is very bad. Okay. But it will progress and it will get worse. Let me see if I can find it. And they will end up obviously going into DIC, and some kids definitely have.
So you said it was purpura and what else? Like
petechiae.
Okay, so just bruising basically?
No, it's petechiae specifically.
Okay.
The little teeny tiny blood spots. If you ever see a petechial rash on a child, you need to assume it is meningitis and immediately implement precautions. A petechial rash is not normal. Now, if the kid's been puking and they have like a little bit of petechiae around their eyes or something, like, yes, I get that. Okay. Or sometimes scratching can cause a little petechiae, but I'm talking, this is like widespread petechial rash, or it may just be on the abdomen. But if you see it and the kid is acutely ill, better do something. Okay. Trying to find it.
So the word
meningococcemia,
that's the meningitis going everywhere
in the bloodstream. Yeah. Okay. So brace yourselves because this is not easy to see, but this is a baby that got really bad meningitis. And you can see like they've got major like clots and stuff in there. It looks like DIC. Can you see? Did I do it right? Okay. That kid might lose their limb. Okay. Because they're not getting perfusion to the limb. So meningitis is very bad. Bacterial meningitis can be very, very, very bad. Do we understand?
Yes.
Okay. So with that in mind, most common bacteria for neonates is GBS. That is not Guillain-Barré. Does anybody know what GBS is in this situation? You can do this. I believe in you. It's obviously a bacteria. Group B.
Group B strep.
Yeah, it's group B strep. Because remember, you don't know because you've never taken OB.
Oh, it's what they find in the mom's vagina.
Yes, or rectum. Yes,
rectum.
Yes, very common.
Very casual.
Yes, she's like, yes, it's found in a mom's butthole. Okay.
Oh
yeah, I did. Okay, and E. coli. Okay, so because that's from mom's butt too. Okay, in infants, it's strep pneumo. How do we prevent strep pneumo? Strep pneumo. Okay, that's fair. Hand washing is fair.
Yeah.
But strep pneumo. I'm going to keep saying it until y'all get what I'm saying. Yeah, it's a PCV. It's a Prevnar, because Prevnar is the pneumococcal vaccine. Okay. And Neisseria meningitis over 2 months of age. There's nothing we can do to fix that one. In kids, it is meningococcal. How do we prevent that one? MCV, which is the menactor meningococcal vaccine, or wash your hands is probably better. Okay. All right. So y'all need to know what are the different bacteria at different age groups. All right. Infants and toddlers. Here's our friend. Poor feeding, tense, bulging fontanelles. This is going to sound very familiar. Now, not every kid with meningitis has increased ICP, but the symptoms are going to look similar because the brain is very angry, right? So extreme irritability or lethargy. What's hypotonia? Floppy baby. Okay. Vomiting, diarrhea. Do they sound familiar? Yeah. Okay. Decreased suck. They have a very weak suck because they're like difficult to arouse. They just lay there, very hypotonic. Temperature instability. Now, not all infants will have fever. They will either have high temp, which is possible, but more commonly when they're real sick like that, they get hypothermia because the brain can no longer maintain their temperature. Okay. May have fever, may not, like I said. They may seize, but usually they will not seize until after the fontanelle's closed, to be honest, because they have a little leeway there, right? The high pitched cry, we saw that coming. What's photophobia?
You're sensitive to like
Right. So they want it dark. Okay. And they may shiver because they can't keep their temp up. Okay. Do we understand infants and toddlers? All right. Now kids and teens, they can verbalize. So we see something a little different. So they'll still have fever, chills. They can say now my head hurts, like, oh my God, it hurts so bad. They'll have nausea and vomiting, which is their way of getting rid of extra fluid. Now it doesn't mean they all have increased ICP, but it is swollen and angry, right? What is nuchal rigidity?
Stiff neck.
Right. Why do they have that? Nuchal rigidity is stiff neck.
The inflammation.
Yeah, it's called meningitis, isn't it? Where are your meninges? Brain and spinal cord. Hello. They're gonna have photophobia, which means, and they may or may not have purpura. If they have purpura, they're bad. Okay, if anybody has petechiae, I don't know where I wrote that. Oh, I did write it on here for you. They may have altered level of consciousness, delirium, like they are not well. Bacterial meningitis is a very big deal. Are you with me? Okay. So nuchal rigidity is a big one to ask for. So we always say, like, can you touch your chin to your chest? And if they can, it hurts too bad, they can't do it. That's nuchal rigidity, stiff neck. Okay. Petechial rash is an emergency for meningococcemia. So if you see a kid that comes in acutely ill with a petechial rash, what's the first thing you're going to do? What's the first thing you're going to do? What's your priority for a patient that you suspect has meningitis? Listening. What's the first thing? This is highly testable, so I'm not giving it to you. What is the first thing you do when a kid comes in and you suspect they have meningitis? Is it very contagious? Quit trying to read your papers like it's going to give you an answer.
Some kind of precaution.
Yes, it is precautions because meningitis is super contagious. Do you want to bring that home to your family? Do you want to infect everybody in the ER while that kid sits out there and wait? No. Number one thing you do is precautions. And since we don't know what's causing the meningitis, we put on droplet and contact until we get the culture back. With me? Okay. After you get precautions, you want to start antibiotics as soon as possible because this meningitis is eating away their brain. Now you do have to get a culture before obviously you start antibiotics or we'll get a bad culture. Okay. Anyhow, so back up to the top. Kernig's and Brzezinski's. These are two signs. Anytime they're signs, they're highly testable. Okay. So they're basically looking to see, like, is your spinal cord mad? That's what we're doing. Okay. And once I show you what they are, then you'll understand why I drew that weird thing. Okay. So, Kernig's, I will show you what this looks like. So both of them, you're going to lay them down. Hold on. Honestly, this is just looking for, nuchal rigidity. You probably could just have them touch their chin to their chest, but okay. Okay. So Kernig's sign, you're going to lay them flat. Okay. And then you're going to put their leg up like this. And then you lift their leg. When you lift their leg, it like pulls on from the back of, and they're like, ah, and they scream. Okay. So you can see, like, the reason why I drew it that way is like you put their leg at a 90-degree angle and then you lift their leg and they are going to scream when you do that. Okay. That is a positive Kernig sign. With,
I don't understand the picture.
you don't understand, you do understand it. Yeah, I know. It's like, I have to show it to you, but then it's like a little cheat sheet where you're like, I get what you're doing. Okay. So then the Brzezinski sign, okay.
Can you just bring both of your feet up?
No, this one you're going to do the neck comes up. So in this one, you're going to have them lay flat and then you kind of pull their neck up. When you pull their neck up, they're going to pull their legs in because you're stretching their neck and they're going to try to like guard it. Do you see what I mean? Like, now I get it. Okay. So yeah, you can have them. All right. So we understand Kernig's and Brzezinski's. Okay. Nuchal rigidity, petechial rash. We got all our big red flags. All right. So we're going to do a lumbar puncture unless they have increased ICP in the weed. That is contraindicated. Okay. You're going to tap them. Now, what is your job whenever you are getting ready for a lumbar puncture? What's a nurse's role in a lumbar puncture? What's your role in a lumbar? Like, this is a very easy, okay. You look at the computer and it's like, oh, the doctor's coming in to do a lumbar puncture. Go, Dima. What are you going to do? Okay. So set up sterile field, prepare the child. We're probably going to call child life. How do you position the child? No, because they won't sit still. On their side, curled into a C, right? So we have good access. Now, the older kids, you can tripod them if you want to sit up on the side, but usually it's easier if they're laying down because they're nervous. You know, it's hard to like sit up and be still, right? All right. So position your patient. That's your job. If we have time before the doctor gets there for the LP, we can put on Imla cream. What's Imla cream?
Numbing.
Right. And that needs to stay on for 30 minutes. It doesn't really do any good to me. All it does is numb the skin. It's not going to, I mean, once it gets into the spinal cord, you still feel it, you know, so I don't know. But anyway, that's an option. Call Child Life. You know that. They're, all right. So then the doctor comes in and they do the tap. Okay. Now, if it's a bloody tap, what are you laughing?
There's a dog. I saw it. It's pooping, so don't look at it.
Oh, well, then why'd you say that?
Ah, shit.
Sorry.
Why am I so awkward when it comes to dogs pooping? Like, how dare you? Because to me, it's just like you just walking around, and then when you got to shit, like you just sit and shit.
I
Like
saw
they
it
don't even
because I saw,
care.
like the little, what is that called? The leash. The leash. And
Did
I'm
she
like,
at
"Oh,
least
yeah."
pick it up?
No, she didn't pick it up.
That is very rude. Anyhow,
Judas.
okay. So if they poke, which you'll see if residents do it, they may have a bloody tap. If you see a bloody tap, don't I mean like that's some blood in the, okay. What does that mean? Because there shouldn't be blood in it, right? Okay. They trauma, right? They probably were digging around in there because they couldn't get into the right space, and that means that there's trauma.
Yeah.
Yeah,
Oh.
they still got the tap, but a bloody tap is like,
You did it wrong.
don't be poking around in there. Okay. So it's not gonna like kill the patient, but it can cause more like problems right afterwards. What is your biggest risk after an LP? No, let me ask you a different way. What's the biggest side effect that pretty much everybody gets
Headache.
after an? Okay, so a headache, normal, mild headache, totally normal. We'll give you some Tylenol or whatever. Okay. What happens to the blood pressure? Pretty much everybody.
Drops.
Yeah. So they're going to get hypotension after an LP because you're poking around the spinal cord. Yeah. So we may have to give them bolus fluids.
Yeah.
Now, if they complain of a severe unrelenting headache, that is not normal.
Red flag.
Yeah. And usually that happens with a bloody tap because they dug around in there too much. Okay. Because how do you position a patient after an LP? After.
Supine?
Yeah, we want to put pressure on it, right? So
Yeah,
anytime you
pressure
take,
on it.
yeah, put pressure on it. So they're going to lay flat also because they may have hypotension, right? So I don't want to like sit them up or I'd be like, you know, there's like a hole in their back. So we're going to lay them flat, supine with pressure on it, right? There's usually a pressure dressing that we'll put on it and let them lay flat for about an hour. If they complain of a severe headache, then that means you done jacked up doesn't mean you jacked up the spinal cord. It just means like you dug in there too much or you took too much CSF. If that's the case, you need to report that. The doctor will come in and you draw the patient's blood, and then you take that blood and you put it back into the hole that you took the CSF out of. That is called a blood patch. And we're basically like filling in the hole where the CSF was that's causing you to have a headache.
I'm like, how would you kind of like estimate how much to put back in there?
They usually do about 30 mls, which is a lot.
Wow.
And then they'll see like, because once you get pressure back, you're like, oh, it's full. Is it-
Okay.
yeah, okay. Anyhow, so you know what to do. You know what's normal. You know what's abnormal with an LP.
Mhm.
Okay. Now in the LP, very, very important. All right. If it is bacterial, it will be cloudy because it's full of bacteria. Normally it's like clear, right? Your CSF should be clear.
Yeah.
Okay. White blood cells will be increased because it's an infection. Protein will be increased because, well, yeah, there are going to be extra proteins in there because your patient is trying to fight infection. So they will make more proteins. And then glucose will be low. How come?
Oh, yeah, I was gonna say that.
The bacteria, right? The bacteria is eating all the sugar because they're trying to grow.
Mhm.
Are you with me? So
Yes.
cloudy, high white blood cell, high protein, low glucose. Okay. Oh, I was like, what's a DOCT? What the is it? When I write that, do a CT first if you suspect. Did y'all see my face? I was
I
like,
did.
why
I
did
was
I
like-
do that? I couldn't think of what that, I thought that was a test or something. I was trying to abbreviate. Anyway, do a CT first if they have suspected increased ICP. Because I want to look and see. I'm not going to obviously drill into their brain if I think that because they have meningitis, but I can do a CT and see if there's extra fluid in there. So do a CT first if you think they have increased ICP, because we do not want to tap them if we think they have increased ICP. Okay. Treatment. We are going to give analgesics for the and fever. And oh yeah, okay, that's no, you're right. Okay, anticonvulsants because they may. Antipyretics. Okay, my bad. Yes, antiemetics.
Nausea.
Yeah, we don't want them to vomit because it increases ICP if they are going to get increased ICP, right? And then we put them on massively high dose antibiotics. Okay, so priority number one for patients with meningitis, precautions. If they don't give you that as an option, you go to number 2, which is
Antibiotics.
antibiotics immediately as quick as you can. Obviously, you have to do an LP and all of that, but they're not going to say that because that's not my priority per se. All right. Do we understand?
You have
Yeah.
to get a
Set up a
culture.
no, you do, but you do want to get a culture through the LP. That's what y'all know that, right?
Yeah.
A lumbar puncture gets your
Yes.
culture. Yes, yes, but they don't ever put that on exams as a priority.
Okay.
It's precautions number 1, antibiotics number 2, cross board. All right, set up a non-STEM environment. Because honestly, we don't have to do an LP, right? We could just treat them with broad spectrum antibiotics or double cover them. So I guess that's probably why they don't put it as like a priority, right?
Mhm.
All right, so we're gonna put them on Vanc and Gent, which those are big. Yeah. Okay, Vanc and Gent are both toxic to
The kidneys.
and
Here.
yeah, Nephro-Odo. All right, so we're gonna immediately put them on NPO status, seizure precautions, neuro check, sit them up right with the head midlines. Is sound familiar? Possible fluid restriction. They're probably gonna be NPO. They're not gonna feel like eating anyway, to be honest. Bed rest, strict eyes and nose. Watch that CBC for
Increase.
white blood cell count. Watch for increased ICP symptoms, which you should be very well versed on now. Watch for sepsis and meningococcemia.
Yes.
Do y'all understand those now?
Yeah.
Okay. Pressure precautions. It's our friend. Okay. Monitor those fontanelles because those fontanelles may tell you before anything else does that we're starting to get increased ICP. Check their hearing after antibiotic use because
They are autotoxic.
yeah, Spank and Gent are both ototoxic. And then we usually will treat the family with rifampin for 10 days. What do you know about rifampin? Turns everything red. It is toxic to the liver. Okay. Do you understand bacterial meningitis? Okay. So let's move over to the viral. Now, most meningitis, whether it's bacterial or viral, will start out with URI symptoms, ear pain or cold or whatever. And then they're like, boo, this one fast. Okay. All right. So viral meningitis can usually come from measles, mumps, rubella, HIV, herpes. What's CMV?
Oh, you never get this one right.
I know. And I don't know why. I feel like I've covered it a bunch of times. Or adenovirus is our last one, but CMV. Come on. It is not. It's a really bad one for neonates. Like it is deadly if they get it. Yes. We are a third of the way there. 33%. Megalo is the second one, but it's not cardio. It is not that either. It's the word for cell. Cytomegalovirus. So you get a virus and then it causes inflammation of the meninges. Okay. Now they get some of the signs and symptoms, like maybe they have a little headache, they got fever, photophobia, a little bit of nuchal rigidity, not that bad. These kids do not look super acutely ill. They may get a maculopapular rash, not a petechial rash. Petechiae is usually bacterial. Okay. Nausea, vomiting, confusion, drowsiness. I mean, they don't feel well, right? But they don't look as acutely ill as bacterial meningitis. When you do the LP, because I don't know until I do an LP, I don't know. So I'm already going to do precautions and everything, right? Before I even get to that point. White blood cell count's still going to be high because they're dealing with a virus, right? Protein, normal. Glucose, normal, because virus don't eat, right? Only bacteria eats because viruses are not alive, right? And it's clear. It's not cloudy. Okay. So we'll treat them with some Tylenol, some antiemetics. Take care. Okay. But we will treat it as bacterial until the culture returns. So some places will double cover with antibiotics, yada, yada, even though they know it's not, you know, some places will do that. Low stim environment, neurocheck, seizure precautions, put them on contact and droplet. We would do for everybody like that. Okay. But viral is not nearly as bad. Do you understand that?
Yes.
Okay. Bacterial is like,
You think viral is worse.
damn. Really?
In my head.
In my
When I hear
head.
viral, I'm like, ooh, scary.
It's a virus. It goes away without treatment, you know?
Yeah, I know. but-
Having bacteria eating your brain is probably worse.
Yeah.
Now that I think about it. Yeah. Okay. Questions on meningitis.
No.
What's your first priority?
Pressure precautions.
No, not
Or
pressure.
just precautions. Sorry.
Isolation precautions.
Yes, sorry.
Second priority.
Antibiotics.
Antibiotics.